Dr. Demetrio J, Aguila III, and I'm the host of the Direct Care Movement podcast, where we talk about where money and medicine intersect and a whole bunch of other questions. We're going to address questions like how do these two interact with each other? And we're going to address topics that maybe you've wanted to talk about in the past, but were too afraid to ask, or maybe you didn't know who to ask, or you didn't know how to ask, or you didn't even know if you were allowed to ask. We're going to dig into that and a bunch of other questions that I'm sure you didn't know you wanted to know the answers to until you listened to us. And I'm excited today to have Jared Meays with us as our guest on the podcast. Jared and I have known each other for a while. Jared, welcome, and thank you for joining us today.
Appreciate the invitation. Looking forward to it.
Sure. So why don't you tell us a little bit about yourself?
Sure. My name's Jared. Been an employer benefit advisor for about 14 years, right around there. About 11 in the industry for about 14 years.
Sure.
So I got a wife and two boys. They're 6th grade and 2nd grade, growing up too fast.
Sure.
But I've been in and around healthcare for that amount of time.
Okay.
Somewhere I never intended to, but my whole entire career path has been touching healthcare in some form or fashion. So whether it was working with hospitals in the past or now working with employers in the insurance space, I've always been around healthcare. So it's where it led me to.
Sure. So now some of our listeners are employers, others are benefits advisors like yourself, or TPAs and brokers, but a lot of our listeners are physicians who have no idea what you just said.
Okay, fair enough.
You may have been speaking Swahili for all they know.
Yeah.
So tell us a little more. What is a benefits advisor, and how does that matter to a physician?
Sure, absolutely. So a benefit advisor is essentially a hired consultant that works with employers. So think of it like someone that helps manage your 401k. Benefits advisors help manage all the benefits that are part of an offering. So if you were to be employed by an organization that offers benefits, you might get health insurance and dental insurance and vision insurance and disability, whatever would fall under that umbrella. The benefit advisor is kind of the conduit between the insurance companies that offer those programs and the employer, because the employer is worried about making widgets or whatever, so they don't have the breadth or the bandwidth to have that in their knowledge base. So hire someone like myself that helps manage everything from a compliance standpoint all the way up to managing claims, helping out with employees when they have issues or concerns when it comes to their health insurance or health care, kind of through that whole spectrum. So essentially we're a middleman, for lack of a better term, in between an employer that purchases health insurance programs and then the actual health insurance, whether it's the companies or whoever provides that coverage.
Sure.
And putting all those pieces together.
Okay. So then if we're talking about benefits advisors and we're talking about insurance companies, we're talking about employers, why should a physician even care about this discussion we're having today? Like where do doctors fit into this?
That's a great question. And I have a story to share too, if that's okay.
Please.
So when my mother was with us, she was really, really ill. So she was seeing multiple specialists, so pulmonologists, nephrologists, the whole gamut. So when she was in the hospital one time, I actually developed a pretty good rapport with one of the hospitalists that was there too as well. And so he was asking, what I did, and I told him what I do. And I told him that primarily I work with employers in the insurance space, and started going down what's called self-funded, right? Sure. And so essentially what that means is employers pay claims up to a certain point. So it's not necessarily the insurance company that's paying those claims. So of those claims that get submitted by physicians and groups for services, it's the employers that are actually paying those physicians. The health insurance company a lot of times is just the administrator of it that's ingesting that claim, and then they're sending a bill to the employer to pay, and then it goes back through that channel and gets paid out to the physicians.
Sure.
So there's that step that's in there, and that's why the connection between employers and physicians is a lot more clear, but it's relatively unknown.
Sure. So then, just by way of analogy, to make this a little bit more digestible for the average person who's not familiar with this topic, a lot of people come in and they say, "Oh, doc, I've got good insurance. I have United Wealthcare. We're not going to use any specific names, right?
Sure.
Okay. So I got United Wealthcare. Okay. And see, it's right here on the card. Well, I mean, in my mind, that's kind of like having a MasterCard or Visa, right? Like MasterCard doesn't actually pay the bill.
Right.
MasterCard just happens to be the vehicle by which the bank that's using MasterCard pays the bill.
That's right.
Right? And so the employer is kind of like that bank, whether it's, Wells Fargo, Citibank, Timbuktu Bank Bank and Trust, whatever.
Yeah.
But MasterCard is the card that you use to say, hey, you could swipe this, right?
Yep.
And so same thing with, United Healthcare. They you show that card. In many cases, they're not actually paying the bill.
Right.
It's the employer who's paying it using their network, if you will.
That's right. Yeah, that's a great analogy because it is just it's that physical form of payment essentially in our digital payment environment.
Okay.
Yeah. So they're essentially like a bank.
Sure.
Exactly right. So the employer is the bank, the insurance carrier could be the conduit, where again, as consumers in general don't know much about insurance, right?
Sure.
So that's why they divert to or progress to, I have good insurance, I have ABC.
Sure.
Right? That is a well-known name, and everyone thinks they're the ones that are covering it and paying it, and that's not the case in a lot of cases.
Sure.
So more and more of those employers are migrating to those vehicles where they are essentially the bank.
Sure. Mm-hmm. Okay. And so that's what you described as a self-funded plan, where the employer is funding the healthcare, but using the insurance carrier as a vehicle.
That's right.
Okay.
Yep.
All right. So where do you fit into that?
So what I do is I help employers establish kind of what the appropriate risk appetite is for whether it's their given population, the size of their organization, or how much risk they want to take on themselves, right? Because if they want to take on more risk, then their costs could go down, right? Because they're spending less out of their pocket because they're taking more on the risk side. So that's really what we help do, is design what kind of risk appetite they have and what that pricing looks like when it comes down to the premiums.
Sure. So let's talk about that a little bit more. So, we talk about risk, and I think, maybe there's a budding understanding of that amongst our, physician colleagues who are listening. But let's dive into a concrete example to kind of help people understand what you mean by that. So, I mean, like for instance, an ear infection, a certain number of the employees are going to get ear infections. The risk associated, the financial, and we're really talking about financial risk, right?
That's right.
So the financial risk associated with that is minimal. I think we can agree, right? I mean, it doesn't cost that much money to take care of an ear infection, right? So that's not really where your focus is, or maybe the focus of the employer is, right? I mean, we're not talking about, most employers can cover all the ear infections for their company without your help.
Breaking the bank without my help.
Okay. So where do you step in to help the employers mitigate risk? What kind of risks are we talking about then? Like, what would be an example?
The biggest examples of right now that I can really give concrete examples is in the pharmaceutical space.
Sure.
So pharmaceutical drugs are continuing to increase in prices. The pharmaceutical companies are really spending a lot of their time, energy, and effort and money and resources into those drugs that cost a lot of money, that are for really, really specified diseases, which, in all aspects are great innovations, in my opinion, too, right? I mean, to be able to help folks with unique diseases or any type of disease that can help treat, I think are great innovations. But for example, if there's an opportunity for drugs to be sourced different places for a lot less. So for example, there was an oral chemotherapy medication that we had a patient or a member that was on that was costing about $300,000 a year. So back into the finance side, that's where we'd say, okay, here's a risk. What are other opportunities that we can do to help with this risk? So that is procuring at other places, working with specific pharmaceutical companies, maybe to get that on a more direct basis rather than through the normal channels.
Sure.
So we bring down the cost of that, which in turn brings down the cost of the insurance back to the employers and the entire population. But from a risk perspective on all, there's only, it used to be the 80-20 rule, right? So
Sure.
80% of the cost are being driven by 20% of the population. So think you got you're an employer with 100 people. 20 members on your plan are driving 80% of the cost.
Sure.
Right. So that's really where when we talk about and look at risk and how to identify that is really where is those high cost risk opportunities, because that's what the insurance companies care about too, because that's getting into their money, right? Everything else below is the employer's money. So that's the ear infections.
Sure.
Right? Don't care much about the ear infections from a financial risk perspective. It's more the top side, high risk stuff that is really becoming more prevalent.
Mm-hmm. Okay. So then part of your job is to help figure out more affordable ways to deliver that same kind of care.
Exactly.
Or potentially better care at the same cost. Ideally, better care at lower cost.
Ideally.
Mm-hmm. Right? How often does that happen in a conventional model?
Very, very infrequently.
Yeah.
It really does, because and you've seen data, we've seen data, you practice it yourself. Other people are wanting to practice it or are practicing it, but in most cases, quality and cost in healthcare is completely inverse to what we think of as a traditional consumer, right? So we think the highest cost car is going to be the best possible car, right? Lamborghini, Bugatti, you name them, right?
Sure.
Healthcare is inverse. It really, truly is, and we've seen it in the data. So the more that the quality increases, the cost actually does decrease and comes down. It's really fascinating. It's unlike anything else in a traditional consumer, whether it's consumer services or goods buying. It's just, it's extremely inverse. I have some understandings as to why, but you would certainly know more than I would.
Sure.
And your listeners.
Well, my guess, and tell me whether or not you agree with this, my guess is that a lot of it has to do with transparency or lack thereof.
Mm-hmm.
Right? In many cases, the most affordable care that's provided is provided by direct care physicians and practices,
mm-hmm.
right? And in order to be appealing to the average consumer, whether it's an employer or whether it's an individual patient, we have to make it affordable. We have to make it accessible.
Mm-hmm.
And then if there's more than one of us, we also have to make it competitive.
Right.
Right? And when there's no transparency, like you see in a typical insurance-based model, then how else are you competitive? Well, you're just competitive based on marketing.
That's right.
Right? That's all it is. It's just marketing.
Yep. The inability, it's come a long way. It's going to get bigger, but the inability for the general consumer to know the price of anything in healthcare is really frustrating.
Sure.
It's frustrating for everybody, right? Because they know I'm sure you've talked about this with other folks too as well, but and I feel really badly for physicians too as well, because a lot of that cost and financial burden has been shifted to them, right? Because, and I'm sure you've talked about this in the past too, but as deductibles have continued to increase, so that's how much an employee or a patient has to pay first before their insurance plan pays anything, is continuing to grow, because that's one way to shift renewal increases on premiums that go up, is to put more responsibility borne on the patient. Well, you think about it downstream, if a patient comes in and they have $3,000 of a responsibility on themselves, that claim gets processed, right, in the traditional environment, and now that physician's office has to come back and ask them for money.
Right. Right. And then the physician's office gets painted as the bad guy.
Correct.
Yeah.
Because they're the one sending the bills.
Right.
It's so, and again, the patients are frustrated, right? Because they a lot of times get a bill and don't understand what it is, why it costs this, without transparency, you mentioned ahead of time. And physicians are frustrated because their payments lag, right? Whether it's from the insurance company side payments or from their patients, because it's high costs, or they don't have the money to pay, or they got to put them on 36-month no interest payment plans, what have you. It's just a really tough financial environment for the two people that matter the most in it.
Right.
Because they've been both taken out of the transaction per se.
Right, exactly. So then tell me, what are you doing differently to address this? I mean, doing the same thing over and over and expecting a different result, has often been defined as insanity, right?
Insanity.
And that's what we see most people doing. My understanding is that employers continue to do this because they're like, you know what? This is too complicated for us to try to figure out, and I don't want to piss off my employees and have them go running off to go work for some other company. So, I think we often forget that health benefits are a recruiting tool and a retention tool, right? That's primarily what they were intended as originally, and that's what they've really become. I mean, I talk to patients all the time who say, well, the only reason I have this job, I hate it, is because of the health benefits, you know, even though those health benefits aren't as good as they think they are, you know? And so, you know, you have the employers who feel like they're stuck, and then you have physicians who feel like they're stuck. And then, you know, the people in the middle who may or may not know that there are other options available to get everybody unstuck.
Right.
So what's your approach?
The approach now, honestly, is baby steps, because there's got to be big enough looking at it from an employer's perspective, right? Like you said, it's really complicated. A lot of times they don't want to focus as much time as it takes or it can take to do this, and they want to get it off their plate as soon as they can and get back on to growing their business, right? And they're also, a lot of times, can be fearful of impact as it brings to employees, which they've felt that and they've done that themselves, and they've gone through tough conversations. I mean, I can't tell you how many educational meetings I've been in where I'm sitting in front of a room full of employees. They had a tough renewal. We did, you know, all that we could, came to an agreement, and you just see this, right, the sagging shoulders, right? So where I'm hopeful and positive, and what we're trying to do is start to make those connections directly between those employers and those physicians that want to start working directly with employers, right? Because they've either done some form or fashion of it in the past, right? Whether it's maybe, say, on the work comp side of things, right? There's some that's been done in that realm too as well. But just helping to understand that there can be those connections that make, so it's starting to make those introductions is part of what I do from the baby step side of things, and help them understand, like, hey, this can be done. It doesn't have to be everything all at once. It can be a little bit of piece at a time. Get comfortable with it so that your employees start to get comfortable with it. And then those interactions just start to blossom, because then what happens is one employee talks to another, talks to 3, talks to 4, talks to 10, right? The biggest way that can be achieved is to reduce or eliminate a majority of the financial responsibility to the employees, because money's an incentive, right? Just like when there's a system, right? We're talking healthcare, but you talk any system, it's based on rewards and resources, right? So if you think of a river running into a lake, right? If you cut off the water to that lake, or to the rip from the river, the lake dries up, right? So money keeps going into the same system. That's a financial reward for it to continue doing what it's doing. If you start to change where that water flows or those resources flow, then you can get a lot better outcomes, right? You can get more bang for your buck for the employee side, the employer side, and the physicians, because they're not chasing financial payment from employees. They're getting paid quicker and faster, and in a transparent environment. And I can't tell you how many, business owners that I spoke with that say it would be nice to know a lot more of what we're paying ahead of time.
For sure. So then let's turn to a concrete example. What would be a concrete example of how this might work, or how it already does work? And what's the benefit to the doctor? I mean, we've talked about reducing costs for the employer and the employee, by doing this direct connection. Well, on some level, I imagine some of our listeners are thinking, well, that's great that you save the employer and the employee money, but I'm already making pennies on the dollar on the work that I do, so I'm going to get gouged even more?
So, concrete example, let me ask you a question. How much of healthcare that an individual would have to interact with would be something that would be predictable, schedulable?
Oh, over 80%.
Over 80%.
Yeah.
So if we think in that realm, so let's use I've had my hip replaced. Okay.
Sure.
So that was a schedulable event done ahead of time. So let's use that as an example in this new direct environment and how it is working or how it can work. So if I'm an employer that designs a plan and says, hey, if you go to this facility that we have a direct relationship with to get your hip done, as an employee, it's going to cost you nothing.
Sure.
Right. So
you go to Hips R Us.
Hips R Us to get your hip done.
Sure.
And it doesn't cost. So as an employee, already for me, it's like, okay, I can wipe the sweat off my brow because I know it's not going to cost me anything, because that's what matters to the patient.
Sure.
Right. Now, as the physician that's doing it, at your practice, if there's that direct agreement already in place of here's what we're going to charge and we're going to send your patient to you, it's not going to cost them anything. So number one, as a physician, I know I'm not going to have to chase any deductible or financial responsibility from the employee or from the patient. Number two, I know that I'm going to get paid whether it's that same day or within a week versus a traditional claim is usually 60 to 120 days.
Typically, yeah.
Typically, so I'm not holding that on my balance sheet. And I know I'm not going to have any bad debt to chase, right? So from that perspective, on the physician side, I'm getting paid upfront or within a reasonable amount of time of a normal transaction, and I'm getting paid what I feel like I'm worth or I'm due based on the work that I perform.
Sure.
So when you remove and pull away a lot of that additional financial responsibility, then it just gives the opportunity to work, grow faster from the physician side of things, to be able to either, do more, make those connections, or just have more time with the patient.
Sure.
Right.
Sure.
And not have to just know it's still in that scenario, right? It's still volume, right? But it just removes a lot of the waste. I don't know a better way to say it, but waste between waiting for payment, time chasing payment from, it just removes all of that. So that direct connection between a physician and a patient is established. And then there's that vehicle, that payment vehicle that helps establish that direct interaction too as well.
Sure. Well, and then on top of that, you don't have to deal with appeals. You don't have to deal with
pre-auth,
prior authorization. You don't have to deal with wondering if you're going to get paid because you're going to get paid. Mm-hmm. You don't have to wonder how much you're going to get paid because you know exactly how much you're going to get paid. And you don't have to wonder when you're going to get paid because that's all outlined in the contract too.
Absolutely. And I'm really glad you brought that up because I failed to mention that. But removing those barriers, because I've talked to some physicians before, and I was like, hey, in this direct environment, if we can remove prior auths, if we can not have to worry about appeals, and if we can have you paid up front and on time, how much is that worth to you? They're like, I don't know if I can put a price on it.
Yeah.
It's funny because I actually wrote this example down that I found, but it was from Duke University.
Sure.
So I'm not sure if you saw this or you talked about this previously, but so Duke University, there was one insurance carrier that denies claims 40% higher rate than other insurance carriers. They win on appeal 97% of the time. Okay, you ready for this one? This blew my mind. They employ 236 people there just to work on denials. That's unbelievable.
Yeah.
So that's a lot of that when we talk about waste and extra resources and money. Like where could places like that, or whether it's a 2-person physician clinic office or 10,000 hospital system, right? They're spending that money there. Where else could that be spent?
Right. Yeah. Well, I think of one of my colleagues here in Omaha. He's an OBGYN. Now, mind you, I run a direct care practice. We don't do anything with insurance whatsoever. We have a very, very streamlined team as a result of this because we don't have to have all this army of people like you talked about to chase down all this money. And I've heard a lot of doctors talk about, well, if I do part of my practice as a direct care practice and then part of it is insurance, I can straddle that fence. I'll tell you, I tried that for a few years, and it actually cost me more money.
Really?
Yeah. I found that you either have to be all in or you have to be all out. Trying to do the in-between is painful, and it's more expensive. And, this one colleague of mine who's an OBGYN here in town, he's in a solo practice, okay? This is a great example of what I'm talking about, okay? So somewhere between 50 and 60% of his practice is direct care. It's mainly people coming from out of the country for their care to see him, and so they don't do anything with insurance. Okay. But he still has to have the infrastructure set up to take care of the insurance patients, okay? He's a solo surgeon. If you had to guess, how many billers does he have in his office for just himself?
3?
11.
11?
4 of whom are dedicated to just Medicare and dealing with the Medicare, you don't do prior authorizations, but they're dealing with all the appeals and then obviously the other 7 are focused on the commercial insurance and all the prior authorizations and then the appeals that are associated with that. Versus how many do we have in my office? 0.
0.
Zero.
Well, I mean,
and 50% of his practice is direct care versus mine, which is 100%.
So he's not even 100%, yeah.
No.
So, I mean, to the listening audience, that's early physicians and residents. I mean, that gives you a window, right?
For sure.
A picture through the window of what it could look like in a couple of different environments. So I love that you brought up that example because now I'm not a physician, if I were going through residency, like that would resonate to me, right? Because if I'm looking at, I'd like to be, I'd love to be independent. I'd love to have my own practice. Mm-hmm. Gives you a little bit of a picture of what two different avenues can look like.
Oh, for sure. For sure. I mean, when you think about that, you take a look at my practice, and my practice, the amount of revenue that I generate has to feed me, my family, and then the families of the two other people that work for me. Mm-hmm. So we're looking at maybe a dozen people versus this OBGYN whose revenue has to feed 70 or 80 people.
Right. Well, not to mention with that new bill that just passed, the continuing resolution, Medicare cut stayed.
Yes.
2.8% less. I think physicians that I read are making less today than they were in like the mid-90s.
Yes.
Does that sound right?
Yeah, that sounds about right.
Where else do we see that? Because wages keep going up for their billers and coders and folks.
Exactly.
Right? But if I keep getting paid, it's the incentives are completely flipped in the wrong direction.
Totally.
And we need healthcare.
For sure.
It's 18% of our GDP. Doesn't need to be that much, but we're on a track where we need to get healthier. We need to get more transparent. We need to have more opportunities to grow instead of shrink.
Right.
Right. Because the shortages we read about all the time between physicians. That's why I'm super thankful for everyone that's listening, that's grinding, that's in there, that's doing it to try and get to become a physician, whether it's whatever their motivation is, right? We need more and more of them, right? Whether it's physicians, nurses, what have you. So I just applaud everyone that's listening that's doing that because it's a much needed environment that's going to continue to grow in many, many different directions.
Sure.
And I love that you're having this podcast too as well, because in my environment, like you said, insanity over and over and over again, it's got to change, right? Is DC going to change it? Probably not, would be my guess. If I were to put money on it, I'd bet the other way.
Yeah, I would too. And obviously there are conspiracy theorists out there who I think at least have a little nugget of truth in some of their thoughts about how we ended up in the situation we're in right now. That's another discussion for another day. But regardless, I don't think the people in DC are motivated. They're not. The incentives aren't in place for them to get the kind of solution that we're looking for, right? And I think ultimately that's really what we're talking about, right? Is aligning incentives. If we can align the incentives properly, we can get the results we're looking for, right? And so many of us want a particular result, but the incentives aren't set up to achieve that result. Mm-hmm. And so what you're talking about really is realigning all of those priorities and incentives so that we're all pointed in the same direction.
Absolutely.
Right?
I mean, when you can get everything pointed to where you want to go, right? The most difficult part, right, is getting all those folks together and in alignment, right? Even internally. I mean, I can't imagine, you've worked with plenty of them, but from the stories that I heard, just having multiple physicians together to get them on the same page with anything,
it's like herding
can be
cats.
Challenging.
It totally is. Yeah, I mean, when I first went out into practice on my own, I remember the CEO of the hospital system that I was working for. He said, "Oh, well, you're going to go join such and such a group, or you're going to hire somebody to join you." And I said, "You know what? I think that's unlikely." Well, what are you talking about? And I said, I'm a surgeon. And I know that I'm a pain in the butt as an employee. I'm like, why would I want to hire somebody else to be a pain in my butt, when I can just be a pain in my own butt, Yeah. I mean, those who are listening, who are surgeons, you know exactly what I'm talking about, right? Okay, so then in an ideal world, if you were emperor, how would you design this? How would you set this up so that those incentives are aligned, so that doctors are providing good care and being compensated appropriately, employers and employees are paying a fair price, and the people that are getting paid are people who are actually adding value to the proposition?
It's a really big question. I've thought about this a lot too.
Sure.
Not sure there's right or wrong answer. I think you have to have some sort. I think you have to you have to look at it like number one, from a pricing perspective or from a purchasing perspective. I think you have to come at it from a purchasing perspective, right? Just like we would purchase any other service. I think that has to be kind of at the baseline,
Sure.
right? Where to start. Then I think you have to design somewhere where, right? I always think of it like auto insurance, right? There's got to be some place where, as a American patient, my financial responsibility stops, right, at some point, and then I pay premium for insurance to take it over and above that. So whether
You're talking about mitigating risk.
Yes, mitigating risk. So 80% of our stuff is scheduled, right? So at some point, would I give someone the option to say, okay, you get to pick where your financial responsibility starts or stops, right? So that can be $500, that could be $10,000. Call it a deductible, call it what have you, but give people the opportunity to select where I want my financial responsibility to stop, and then I'll pay premiums for over and above that. So the challenging thing of that is, how do you do that, especially in the environment that it's at today? But I truly feel like if you can start bringing in that type of purchasing mentality into the marketplace, and then allow physicians to set their prices where they want, and allow them to be paid in a timely manner up front, that just bridges that trust between the patient. And if they're good, then guess what? They're going to get referrals, word of mouth, like anything else they do today, but even more so, especially with it being online. If there's a struggle, they're going to have to work through that too as well, right? Could be a learning opportunity, but right now there's not as much of that that's out there to give them that feedback, right? The
Sure.
feedback that they get is from the insurance carriers on what they're saying. No, we're going to direct more of our care and pay higher reimbursements to our physicians that we own.
Right.
Right.
Exactly.
So it's not a true free market, fair market.
Exactly.
So that's what I would design is bring in that transparency. I'm going to pay out of pocket. I would unlock HSAs from that perspective and let them be used more widely available for people to save. So that's a way to save pre-tax money or in a savings account to pay for medical expenses.
Sure.
I'd grow that.
Sure. Mm-hmm. Okay. So then I love the idea of bringing people back to like an auto insurance model, right? Because I think what I've seen, and I mean, you've heard me say this before. I started in healthcare when I was 10 years old. Working in my dad's office. My dad's a retired physician, and I was scrubbing toilets and emptying garbage cans.
Right.
But by the time I graduated from high school, I'd done everything there is to do in a doctor's office, other than be the doctor. Right. So I have some understanding of what goes on behind the scenes. Well, even more so now as a business owner. Right.
Sure.
But the idea of insurance, when people started using it to see my dad, it was very much like, it was very much like auto insurance. Like, would you, if a tree falls on your car, who pays for that? The insurance company does. And after you've met your deductible, right? Your car gets struck by lightning or falls into a sinkhole. Who pays for that?
Yeah.
The insurance company does. But you don't expect the insurance company to pay for your windshield wipers or your oil change or to put gas in your car, right?
Nope.
Because those are things that don't meet the insurance criteria. But when we talk about insurance in general, setting aside health insurance, homeowners insurance, life insurance. Maybe life insurance isn't such a good example, but homeowners insurance and auto insurance are two great examples. Things have to meet two criteria for it to make sense to use insurance, right? It has to be unexpected and catastrophically expensive.
Yep.
Right? Putting gas in your car should not be unexpected. And, barring really horrible inflation, it shouldn't be catastrophically expensive either. So It makes more sense for you to pay for it yourself. But somehow or another, we've ended up with a healthcare system where we want our health insurance, or I shouldn't say we expect. Our health insurance to pay for the oil change, to pay for the wiper blades, and to pay for the gas that goes in the car. Well, when you add in a bunch of extra layers of bureaucracy, what's going to happen to the cost?
Keeps going up.
It keeps going up.
I
mean, it makes sense. Those people have to feed their families too, right?
Sure.
In fairness to the insurance companies. I mean, I have my biases regarding the insurance companies, but ultimately, all those people, they have mouths to feed as well.
That's right.
And so the question is, should we be feeding them or should we be feeding somebody else?
Right.
right? So
Or feed them a different way.
right, exactly. Exactly. And so then, by bypassing that with the direct model that you described, then we've got funds available to pay the doctors and the nurses and all the other healthcare people more fairly. We've got funds available to redirect some of those back into wage increases, for the employees, because then the employer now has flexibility to say, I've got money available to use a different retention tool for the employees I want to keep on. Instead of spending all of that money on their expensive healthcare plan, I can provide them a different health plan, which is more affordable, provides better care, and now allows me to pay them more.
Right. That's the retention tool.
Yeah.
Right. The old way is right now it's a necessity.
Sure.
So if you can turn that necessity into a really valuable opportunity, then and save money at the same time, across the board, you can reassert money so many other places.
Oh, for sure.
Right. But it's a big lift. It's going to take a lot of years. Right.
Sure.
But it's going to take a grassroots effort, as it's been from my understanding up to this point, right? From what I've seen is just folks talking and it's one of those things where the fever pitch is coming, right? And we talked a little bit about this before, but certain instances that have happened recently, it's just brought kind of that foam is rising to the top as far as the frustrations from all parties.
Oh yeah. I mean, there's all kinds of frustration. We've seen it, we touched on it earlier, and let's discuss a little bit right now. I mean, we think about what happened to Brian Thompson at United Health, and I mean, that's a tragedy. That's absolute tragedy. Nobody should lose their life over these kinds of things. The fact of the matter is that all kinds of people are losing their lives, whether it's directly due to decisions that people in his position made or not. People's lives are being affected, and as a result, there's a lot of frustration.
Yep.
Right? Clearly, a lot of frustration. Now, obviously, the jury's still out on whether or not the person who everybody thinks did this actually did it, or whether there's something else going on. I mean, the facts aren't all available yet. It doesn't change, however, the fact that a lot of people are really, really frustrated. We see that in the comments on all kinds of social media about how people feel about this whole situation. In your mind, what kinds of frustrations drive people to do things like that?
Specifically in the environment we're in today, I could kind of speak to that.
Sure.
So when we purchase healthcare, right? Health insurance, I should say. Pay a lot. Which is different, right? Which is way different. Not even close to the same thing. We pay a whole bunch of money in premiums. 50% roughly, maybe not even use it, right? But we're paying a whole bunch in premiums. Then when I do have to use it, then I have to pay more. Then when I do actually need to use it and I do have to pay more, and then it might get denied. Especially for the frustration can come when it's to yourself or to a loved one. That's hard, right? That's hard because especially when it comes to those types of instances and circumstances, it's right when it's life or death and someone's saying no, or it's not getting done timely, or I'm paying a lot, now I got to pay more, and I'm already been financially strapped because, I have $1,500 maybe in my savings account, and then I get a bill for $3,000 for something that I had, and I can't pay that, and I'm still trying to put food on the table with inflation that's come, right? You can see how frustrations like that can compound because healthcare inflation, health insurance inflation, however you want to compound that, that's been compounding and growing for the last 20 years, right? On a relatively higher scale than general CPI. Well, now that CPI has really grown, that pressure has felt even greater.
Yes.
Right? And it's continuing because wages are going up for everyone, right, across the board, so that gets passed along somewhere and somehow. So I can't speak to how an individual psychologically can get to a point where they feel like that's their only option, right? But I can, the frustrations in the marketplace certainly are palpable.
Sure.
Right. And it's there's going to be calls. I don't know that there's going to be anything materially that comes from it out of DC. Like I said, I don't trust that there's going to do much, but that remains to be seen. But certainly, obviously, taking someone's life is horrendous, and how he leaves family behind. But on the frustration side, it's there, and it's been there for a while, and it's just going to continue to grow if opportunities are not taken, like what's happening in the direct care space.
Sure.
Right.
Sure.
Because the system, right, it's feeding itself, right? So
it's eating itself now.
And now it's eating itself.
Yeah.
So change has to come at some point. It's just who's gonna do it and how.
Mm-hmm. Yeah, I mean, I agree 100%. And when we take a look, if you think about what happened to Brian Thompson, that's a symptom of a much deeper and much bigger problem.
Right.
It's horrible that it happened. It's even more horrible that it points to something much, much more profound.
Right.
Right. But there's hope, right? There's hope. Like when we think about, I'll use an example. My wife underwent a CT scan at a hospital, at a local hospital. I'm not going to name the hospital, but underwent a CT scan at a local hospital. And because of the circumstances, we didn't have the time to get it anywhere else. And when we got the bill, it was $3,800. Turns out there's a facility right here in town, Nebraska Health Imaging, that'll do that exact same scan for $250. That's a big difference, But in that difference is an opportunity, an opportunity to provide hope to people to make healthcare more affordable and more accessible by cutting out all those extra mechanisms which add on cost without adding on value.
That's right. Yeah, we see those scenarios happen all the time within
sure.
data, whether it's, those scans, those are great examples because it's very transactional. It's something that happens routinely and consistently all the time. So those are really good examples to use and to highlight, like, you're right. There's much differences between having that done at a hospital, freestanding, and even the facilities themselves. If they own freestanding clinics or outpatient, they know the difference. They know their cost difference in the two.
Oh, for sure.
So it's just without that, what do they say? Sunlight's the best disinfectant. Got to start bringing in more of that cost transparency. Tried a little bit with some of the transparency files. Those are really tough for any consumer to read. Myself, I'm in the business, and they're a challenge to go through.
Oh yeah, I mean when the transparency law went into effect and the hospitals had to post that. I mean, I think 5% of hospitals actually post those numbers, but the ones that do, the vast majority of them put it in a format that I can't decipher. No. I figured, I'll be able to go in there and look for CPT codes and E&M codes, and it uses a whole bunch of other kinds of codes I've never even seen before. And I was like, well, how the heck am I supposed to find out what a cholecystectomy costs, or what taking out somebody's tonsils costs?
Yeah, right.
I can't even figure out how much it costs to do simple blood work. But they say it's transparent, Yeah.
But they're going to do just enough
to meet the letter of the law.
To meet the requirements.
Yeah, exactly. But compare that to people who are doing direct care, and it's all very transparent in the truest sense, right? People look and they say, oh, so this is how much this costs. And then who makes the decision about whether or not to purchase that care? The patient does.
Patient does, sure.
Yeah. And so the patient is back in the seat of power where the patient should have been in the first place.
That's right. Right. And that's really the one of the most difficult challenges is I'll say, is that in the health insurance environment, patients, I would probably say physicians themselves too, don't know the cost.
Right.
Right? Or even if, let's say as a patient, if I get that letter that comes to me that says what my responsibility is, called the explanation of benefits.
Right.
That comes to me and I can see like charges and discounts and everything. Where do their eyes go?
Straight to the doctor.
Right?
Oh, yeah.
And what do I owe?
Yeah.
Okay,
exactly.
so they might not really take the time to see like this cost $700.
Right.
They're going to say, okay, I owe $45. And that's to them, that's how much it costs, not here.
Right.
So that's the disconnect that's between there. So bringing some of that again into their purview, like whether it's going to get my labs done and knowing that I can get my labs done for this, full panel, whatever, to be able to see them be like, okay, this is great. And then to have the time to spend, again, I think that's a lot of piece that gets missed is how much, and you could probably speak to this even more as far as how much more time that you get to spend with a patient with whatever they're there to see you for.
Sure.
Or to be diagnosed for.
Yeah. I mean, I could definitely talk about that. As a matter of fact, I'm going to be talking about that at the Free Market Medical Association meeting in April in Oklahoma City. I've been invited to give a TED Talk, and tentatively, we haven't nailed it down for sure yet, but I'm pretty sure the title is going to be How Free Market Medicine, How Direct Surgical Care Saved My Practice from Bankruptcy.
Ooh. If that is not just a tickle for the audience to listen to that, that's great.
Yeah. And I'm going to give very concrete examples of how that's the case. And so for those of you that are out there wondering, well, is it possible? Can we actually make this work, or is this just some kind of pipe dream? I'm going to talk about exactly how it happened and the mistakes that I made and the lessons that I learned from those mistakes.
That's great that you're sharing that knowledge.
Yeah.
And that playbook, because I think the direct care movement, you're a pioneer. So kudos to you for taking that leap and taking your lumps. I'm sure there's been plenty.
Oh, lots.
But to share that with those that are coming up to be physicians and be practitioners, I think is super helpful, because you need a playbook. I mean, this system, this environment is extremely complex to the point where it's even hard just to talk about, because you can go down so many different pathways on specific topics and areas that makes it really difficult to really get the meat and bones or get to everything. But what it really comes back to, if you want to boil it down, again, like anything, it's follow the money, right?
Yeah, for sure.
Follow the money. So let's follow that money and start making those direct interactions happen more frequently, so that it takes out, we don't have to know where it's going.
Sure.
We don't have to question where it's going.
Exactly. Mm-hmm. So as we tie up here, this has been a great conversation.
Enjoyed it.
I think we need to have another one.
I'd love that.
All right. Well, we'll have you on again. What is your advice to the core of our listening audience right now, the medical students, the residents, the physicians who are fresh out of training? If there's one thing that you want those people to know, you want them to walk away with, what is that one thing?
Let me think about this for 1 second. There's a lot of physicians out there that I've talked to and I've met that are wishing they were in your shoes. And what I mean by that, not necessarily that they're back in residency and going through that, right? But the fact that there's so much more of these types of opportunities that are available, and the knowledge sharing that's happening in the space, they're like, I would have done things totally different, or I would have tried to do things totally different, right? And I can understand that, the financial burden that's placed on physicians, nurses coming through school and understanding the debt and how that has to get paid for, right? And understanding that. But that's one thing that I've heard is, man, you mentioned Keith Smith in some of your other podcasts.
Sure. He's been a guest.
He's been a guest. That's right. I'd love to do something like that. I wish I could do something like that. There's those opportunities. So I'd say one thing to leave with is just to be like really, really hopeful and understand that your path doesn't necessarily have to be what it has been for the last 50 years. It could be something completely different, and know that you're always going to have patients that want to be taken care of.
Right.
And as that environment changes, that would allow your scope to expand, in my view, right? If I'm there's a lot more that I could do in areas of whether it's, helping folks or educating folks even more. So that's what I'd say is be hopeful and find those social channels of those docs that can help be like yourself to be a resource for you, so that you can ask questions confidently, right? I've listened to some of your other podcasts as far as some of the fear that exists, and I'd be in that same position too, of speaking out, but finding some of those, channels, whether it's social or phone calls and conversations to have, just to start the wheels turning on that. So I don't know if that was
that was great.
A good enough piece of advice, but there's
perfect.
something.
So then, last question. how do people find you? How do these medical students, these residents, employers, anybody, somebody that says, you know what, I really like some of the stuff that Jared had to say. I want to ask him more. I want to learn more about this. I want to see if we can collaborate. How do they get a hold of you?
Best place is probably on LinkedIn. I would say is to connect with me there, and then we can have kind of direct interaction and get on more on a one-on-one basis. But I'd say that's the easiest place to find me.
Sure.
Is on LinkedIn, and I can share that.
Yeah, for sure. We can make sure that all that's in the show notes. So
yeah, that'd be great.
Perfect. Okay. Well, thank you, Jared, for joining us today.
I really appreciate the opportunity. It's a pleasure. Yeah.
And thank you, our listeners, for joining us today on the Direct Care Movement podcast. It was exciting to have Jared on today. And if you are interested in the kind of stuff that we talked about today, you found it interesting, you want to learn more, make sure you share this podcast with your friends. Listen to the other episodes. We've got a total of 4 seasons that we're planning to put out, and maybe even more, depending on how many of you have more questions and topics that you want to discuss. So hang on and get ready for an awesome ride. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.